Hi everyone, and welcome to the second session of Digital Context webinar series. This is Mahmoud Al-Bashri with you today from Digital Context International Academy. It's our pleasure and honor to welcome our guest speaker, Dr. Taseef Farook from the University of Adelaide, Australia. Dr. Farook will share with us his experience in job movement analysis within the digital workflow. Dr. Farook is the HDR Scholar, Research Assistant, and Academic Tutor for Dentistry at Adelaide Dental School, the University of Adelaide, Australia. In 2017, he graduated with the Bachelor of Dental Surgery from the University of Dhaka, Bangladesh. In 2020, he got his Master of Science in Dentistry from University of Science, Malaysia. In 2022, he started his PhD journey at the University of Adelaide, Australia. Dr. Farook is a self-motivated healthcare researcher, PhD student, business entrepreneur, and dentist with a broad experience in digital healthcare and research across multiple countries and cultures. He has experience working with large cohorts of patient, staff, and research participants in professional practice, has served as a student leader for multiple research teams and awarded over 400,000 Australian dollars in funding and scholarships for different organizations for his research in digital healthcare. He has been a part of several projects concerning medical imaging and 3D scanning, CAD/CAM, additive manufacturing, medical biostatistics, dental material characteristics, data mining, and medical machine learning. He has a professional and volunteering experience in handling university administrative tasks, volunteering experience in organizing and leading workshops in integrity and ethics, public speaking, conducting public health campaigns, and academic teaching. He has worked globally with multiple universities and clinics, presented at various international conferences, and publishes his work with highly reputed peer-reviewed journals. So during this webinar, Dr. Farook will delve into the latest techniques and tools used for job movement analysis, showcasing how the digital workflow can enhance accuracy, efficiency, and patient outcomes. So just before Dr. Farook starts, I would like to mention that you can write down your questions and questions on the chat or the Q&A section, and in the end, Dr. Farook will answer these questions. So without any delay, let us once again welcome Dr. Farook with us today. Taseef, thank you so much for accepting our invitation and be with us here today. So please share your screen.
Thank you so much for the opportunity, Dr. Al-Bashri. I will begin to share my screen right now. Okay, so for this webinar, I was hoping to briefly go over jaw movement analysis and how it can contribute to our clinical practice as well as clinical academia. So what that means is, for this session, I wanted to discuss the types of digitization techniques that are out there right now for jaw movement analysis. And right off the bat, a lot of practitioners ask, why do we need a digital quantifying method to diagnose something that we can just see or hear, or maybe just evaluate using our readily available tools? So I want to talk about some of the common factors that affect jaw movement, and then talk about how we can use digital techniques like electronathography, electromyography, and non-invasive vibration analysis to evaluate jaw movement, the TMJ, and the muscles of mastication that are responsible for the movement. Now, it is very important to emphasize on the non-invasive aspect of it, because a lot of the definitive diagnoses for jaw-related disorders are made through either CBCT scans or MRIs. Now, that in the context of countries like Australia requires a referral and a very long wait time, as well as it induces a lot of costs that might or might not be covered by health insurances and government subsidies. So having a ready at hand quantifying method to evaluate whether this warrants a referral or whether this warrants specific treatment or just for participant or patient education is very important. Now, we need to bring it all together because there are different methods of analyzing different components of jaw movement, and there are many ways. And as you can see right here, I have worked with almost most of the jaw movement analyzing devices and techniques that are currently available in the market, starting from very basic electrognatography to optoelectronic scanning. And I won't be naming any brands, but I've had the good fortune of working with different people using different scanning systems and using different measurement tools. And in the process, we have worked on creating several systematic reviews on the topic, and most of them have been published with pretty well-reputed journals. So what I'm talking about is from my personal clinical research experience, as well as from the experience that was previously documented. So some of the common dental factors that can influence jaw movement are iatrogenic, which usually is an occlusal high spot or post-orthodontic treatment complications. Sometimes it's because of an ill-fitting denture. Sometimes it's because of trauma, like a fracture. Sometimes it's temporomandibular joint disorders. Sometimes it's a tooth loss, especially the third molars or the first molars. Now, parafunctional habit does not immediately cause deviations or disruptions in physiologic jaw movements, but severe bruxism or severe attrition that is a cause of some parafunctional habit can lead to deviation from the norms. And we have seen this several times in the clinic. Some of the non-dental factors, which are of quite a high interest right now, are the sex hormones, the gonadotrophins, the inflammatory disorders or the autoimmune disorders like osteoarthritis, corticosteroid therapy, disruption in growth like growth hormone deficiency or excess, and even sleep disorders like obstructive sleep apnea. These have all been shown to affect jaw movement, growth, and the musculature to certain degrees. Mental health condition, which is a very hot topic for exploration right now, has also been shown to affect a lot of the TMDs that are happening. And finally, there are some evidences to back up that claim. When a person comes down to the clinic and they say that my jaws are aching, we usually, right off the top of our head, ask, are you stressed? Previously, there wasn't any quantitative measures to understand whether this had some basis to it. We would usually attribute this to an increase in maybe inflammatory mediators because of stress, but now we can actually quantify this using digital techniques that can correlate history to the movements directly. Now, by magnetic electrognatography for this webinar, what I mean is a method by which we can quantify the range of motion, the canine guidance, protrusive guidance, movement velocity of the jaws, the stability of rest position, the intraocuspal point, the freeway space, and the normal and abnormal chewing patterns, all of which are responsible to a certain extent on how physiologically your jaws move. Now, let's start with the very fundamentals and basics. And all of the images and most of what I will be talking about is from our clinical experience with different participants. Now, the first range of motion that is of importance, which is very basic, is the deflection versus deviation conundrum. Now, a deflection would be a lateral deflection or a reduced range of motion that causes the jaw to move to one side while at maximum opening. Now, it might be measured using scale, but it does not give us a quantifiable or reproducible result every time, because usually a large deflection with a normal range of motion, like you see in this image right here, might indicate a chronic displaced disc. But then we have deviations where the jaw deviates to one side during opening or closing, but returns to center point at maximum opening, which might suggest a resistance on the ipsilateral condyle. And if it is during opening, it's for ipsilateral condylar displacement, or if it is resistance during closing, it might indicate a contralateral condyle involvement. So it's quite important, but this is the first step of the way. The second step would be to understand the range of motion. We usually use Bowie gauge or maybe some calipers to measure the lateral movements or the protrusion or the mouth opening. But when we use quantifiable methods like electrognatography or optic tracing, we can put numbers to it, which are usually reproducible. You can see right here that the maximum vertical openings can be recorded. The lateral excursions can be seen right here. The anterior protrusions can also be seen, and it can be quantified here. Like this is the normal mouth opening, these are the left and rights, and this is the anterior protrusion. So we can also measure the opening and closing velocity. But before that, we need to understand how the protrusive guidance can help us understand how the occlusion is interfering or maybe aiding in the person's phonetics or perhaps contributing to lisp or stuttering. So you can see right here that fricatives and sibilants are two consonants that usually produce distinctively different wavelengths on the vertical and the lateral planes. If we know the norms of what we're supposed to expect, we'll know exactly if a person who has, say, a deep class 2 and has a very high overbite is actually in an IOPA classification of 4 or 5, depending on whether their function is being impeded or not. Before, this was based on best judgment and best practice, but if we have quantifiable measurements, it helps us avoid any kind of questioning, litigations, as well as it serves as a supportive document for our referral letters as well. So you can see an example right here. Now, this particular person had an open bite. How is pretty important, but I would like for you to just compare the two readings right here. This person had a right deflection during sibilant phonetics due to a left-sided posterior tooth interference that they had at some point when they had a restoration done. And this causes some deflection, which is why their sibilants acted up differently, and you could hear it, but it wouldn't have made much sense unless you've seen what was going on using some graphical or quantitative outputs. On the other hand, a person with a class 2 division 1 malocclusion with rotation of the central incisors would produce exaggerated vertical displacement during sibilant phonetics, like you can see right here, due to an anterior malocclusion where the tongue does not have a contact point or is latching off of the teeth without producing the push that's required for the sibilants. Now, this often leads to lisping as well, and this can actually help us understand whether the lisping is because of a soft tissue disorder or a dental malocclusion. And we can also use this with velocity analysis to properly understand if it is a jaw joint related disorder or a dental disorder, a musculature issue, or something more neurological. Now, for velocity analysis, I have put up a normal velocity wave right here from one of our participants. Now, if you see that there is an abrupt reduction in opening velocity, like you see right here from another participant, it might possibly indicate a reducing disc displacement at some point with restricted anteroposterior movement. Now, this might not mean much, but see the anteroposterior movement here and see the anteroposterior movement here. So it does not cause the patient immediate discomfort, or it's not something alarming until it becomes something like that. So it's very important to know what the patient is going through from a very early stage so that you can at least give them some advices or maybe provide them with some night guards which might help relieve problems or might prevent problems further down the line. Now, velocity analysis can mean a whole range of things. Like for this participant, I've put some textbook images below, and these are images from our clinics. So the first velocity movement chart that I want to show you is a normal opening, which is supposed to be a proper bell shape. Opening is fine, as you can see on the right, but during closing, there is a slight deceleration while in the closing point. Now, if it was somewhere here, or if it were somewhere during opening, we might have attributed this to a disc displacement. But for this particular participant, what you can see is it's reducing right here during the closing step. And as you can see from the textbook outputs, slowing down during approaching occlusion often means that there is a soft tissue or a hard tissue obstruction. Now, if we move away from the books and if we go back to the clinics, we will find that this is happening because of the participant's enlarged lower lip. The lip and the anterior malocclusion leads to the teeth and the lip making first contact and the lip slowly gliding in front while the teeth go into an occlusal contact. But for the next participant, what you can see is there are a lot of squiggly lines in the opening and the closing as well, which means that there is deviation during opening reduction, there is closing displacement. The participant has a multitude of TMJ disorders right there. And this is our first sign that something might not be right on the occlusal level. And that kind of warrants a higher level of investigation in the clinical practice. Joint vibration is another tool that we can use to non-invasively figure out if there is some abnormalities with the joint movements. Now, this might be a very squiggly line right here, but if you pair it with the jaw movement traces, you'll understand where the clicking is happening and which joint the clicking is happening, as well as what kind of a trace is it. Like for Piper to classify different kinds of joint vibrations based on the type of disorder that might be happening, it can actually give us some understanding of what the patient might be going through, and it might warrant a future referral, or it might warrant us to be a bit more cautious in the treatment that we provide them. Like for this example right here, if we use a joint vibration analysis alongside a range of motion chart, so we see that this is the opening and closing movements, and you'll find that during closing, even when we ask the participant to click down like this, now you would expect that in a balanced occlusion or in a normal occlusion, the clicks will be even on both the left and right side. And even if there is some transference, both of them will resemble the same shape, with one having a higher amplitude than the other. But for this case, what you can see is for the right side, there is a higher frequency click, while for the left side, there is a lower frequency click. Now, one possible reason for this is a possible right-sided obstruction or left-sided muscle hypofunction leading to a decreased left-sided closing click, meaning that the person cannot exert enough force on the left side, which, if is not addressed, will lead to the person preferring to chew using the right side more because they have more control over this, leading to an aggravation of this problem. And you can see right here that velocity tracing can help in the matter. Like for this person, you can see that the range of motion or the opening, she was a person of a very small stature with a small jaw, so I wouldn't really attribute this to much, but they had a normal mouth opening, and the direction of movement did not have any deflections. It did not have any deviations, but you can see right here that there is this tiny little squiggle right here. This is usually seen in case of food impaction, a poor fitting denture, or a habitual tongue biting. For this person, they had an habitual tongue biting whereby they bring their teeth into occlusion and then they subconsciously bite their tongue before they move on to the next step. Now, tongue biting in itself can have a lot of problems down the line, including an enlarged tongue, a scalloped tongue, and sometimes even burning mouth syndrome if a nerve gets severed in the process. So it is also very important to have a look at. Now, the velocity graph and incisal malocclusion, I've already talked about this a bit, but if you can see the malocclusion right here, the upper right central incisor makes contact with the lower lip first, which is why there is this tiny deflection right here. So what I want to emphasize here is, irrespective of what the graphs show, we need to have a thorough understanding of how the participant or the patient is reacting during the process, because a clinical eye alongside these digital observations can give us more clarity on what we're seeing, as opposed to just looking at these numbers right here. Now, if we're looking at functional limitations, like I said previously with the IOPA classifications, and understanding whether this requires an immediate referral, whether this should be covered based on functional impairment or not. And this is mostly an insurance-based thing at some point. But you can see right here that for a person with class 2 division 1 malocclusion without speech or functional interference, the left and right jaw movements or the lateral excursions are usually very baseline, because phonetics usually focuses on the vertical and the anteroposterior movement, not the lateral. But for someone who has a class 2 division 1 with a speech function interference and mild lisping, you will find that the anteroposterior movement and the lateral movement are very prominent or pronounced during the entire process. And when we go to chewing, you can see that even more. Like this person right here, they have a clear facial malformation, and they do not really know what they have unless you show them using some form of media. Now, they were absolutely fine with whatever they had, and they weren't aware of if this was normal or not. But you can see right here that the chewing pattern on the left side is clearly jumbled up right here. The right side is somewhat consistent, but the left side is completely all over the place. And this is just because of how their craniofacial structure is presented. Now, you might be thinking, or you might be skeptical that as to how this is relevant for dentistry as it's on its own, but it's pretty important before we make any plans for dentures or implants or even orthodontic treatments moving down the line, because clearly one side of the face is more active than the other. So the load-bearing capacities on both sides are not equal, even if they have a full dental arch with one missing tooth. Now, subsequent muscle activities you will see right here is that there is marginal asynergy between the right and left sides right here. And if I were to compare it with an older participant, but who has, say, a normal occlusion or a balanced occlusion, you will see that the synergy between the right and left sides are pretty consistent. Even if the muscles on the temporalis and the masseters are weaker than one side over the other, but it's still consistent. There is no asynergy. And if we're talking about rest positions and synergy, there are non-dental causes that relate to unrest. Sometimes we attribute this to white coat hypertension, but sometimes if the patient has, say, a medical condition, like for the first patient, they had a muscle hyperreflexia, and the second patient, they were under methamphetamine treatment for the treatment of ADHD. Now, for them, their muscles are almost always active. You can never find them at rest. So their occlusal status, irrespective of how you set it, their muscles will be hyperactive for the entire duration of occlusion, movement, chewing, and everything. So you will find that even at rest, their muscles are hyperfunctioning, which is why they end up with more TMD-related symptoms without an evident TMJ component or an occlusal component. And I will discuss all of this when I bring them all together for a few cases later on. And if you see the subsequent maximum muscle activities, you can see that it's all over the place. Now, I just want you to keep this in your memory before we move on to the next slide, because it's all going to make sense there. Now, if we have a look at protrusive mandible and muscle functions, you will see that usually with retruded or distalized mandible, the first hyperactive muscle will be the temporalis and then the digastrix. Now, for this patient right here, you can see that they have a bimaxillary protrusion with a limited mandibular protrusive capacity. So, which is why their masseters activated first, but the temporalis were hyperactive for the entire duration. And then they fired up, but in very limited capacity, meaning that their muscle activity is greatly hindered by their occlusal conform or their skeletal formation of the jaws. On the other side, for a person with a normal occlusion or a class 1 skeletal classification, you will find that the protrusive mandible will first hyperactivate the masseter muscles, as you can see right here. But for a normal person, they should all fire up in the same time. Albeit that the temporalis and the masseters might not be firing up in the same capacity, because in the protrusive action, the masseters fire up more, but it is there and it can serve as a strong awareness campaign tool, or maybe it can serve as a way of justifying why the person needs the treatment in the first place. Now, now I will track back to this slide right here, the maximum muscle activity, and I want you to have a look at these muscle activities right here. So there is a clear difference. Now, the first case is a normal muscle function. You will see that the synergy between the left and right temporalis and masseters are almost all over 70%, which is usually considered the norm, because in medicine there is no fixed number, rather a range, and it is suggested that if the two sister muscles function within 70% of each other, they can be classified as normal, unless there is reason to believe that something else might be influencing their detriment. Now, for the second case, you will see that their lower face is a bit more skeletally enlarged, if that makes any sense. And for the for a skeletal lower facial form such as this, we often find that there is a central masseteric suppression, and this impedes the synergy of the two muscles around the lower face, which are predominantly picked up on the masseters. You can see right here that the temporalis are fine, but the masseters are below what you would normally expect to find, and the synergy is pretty low here. And at the same time, for a class 1 skeletal relationship, you'll find that everything should be normal, but then for this participant right here, their masseter muscles were through the roof while their temporalis were hypoactive. Now, this can be caused by a range of things, and most of the times the patient or the participant won't be aware of this, but masseter muscle hyperactivity with a decreased temporalis muscle function in a class 1 face form might suggest possible parafunctional habits such as bruxism and night grinding, which might be the case for this participant, which can be confirmed with an intraoral scan. And this helps understand the need for treatment, how it can be planned out, and also raise awareness in the patient so that you can preserve any kind of restorative treatments that you do for the person in the process. And there is another sequence called the chewing and the silent periods. The silent period is usually there if, there is severe occlusal interferences. Now, you can see that this is a normal chewing cycle right here, where the temporalis and the masseters come live and the person chews with their preference. This person clearly prefers the right side for chewing, but that's not a bad thing. But for this person right here, you will see that between the chewing cycles, there is a latency period right here. There's a latency period right here. This is when their occlusion is so imbalanced that when they're chewing, they need a moment to reset their occlusion, and they bring it back before they resume chewing, essentially disrupting their physiologic chewing patterns, which warrants treatment. And if you can show them that, all right, this you don't, if even if you don't care about how you look, it is happening, and you are uh, eventually tiring your muscles out because they need some time for your occlusion to reset, and then you can start chewing, and it helps the person be more aware of where they're at with their occlusion and their muscle functions that are affected by it. Now, muscle hyperfunction in lateral excursions are also very important. For the first person, you can see that if we ask them to move their jaws from left to right or right to left, the contralateral muscles should activate when you're moving away from them. And you can see it pretty well right here. And they have normal muscle functions. But what happens if someone has maybe a hyperactive muscle, or maybe their muscles are too active irrespective of wherever they're going, and that might be a cause of the TMD right there. It does not have an occlusal component, it does not have a joint component, it's all about the muscles. And this is what you can see right here, that the left temporalis is active throughout the entire cycle, whereas the digastrics act up irrespective of whichever direction they move, meaning that their muscles and the masticatory component are tensed for the entire duration, and perhaps there might not be a joint component to it entirely. Now, let's bring all of this together. Now, for the first case that I showed you, there was a deflection, there was a deviation during closing, and if we look at the lateral excursions, they're more or less equal on the right and left side. When we were looking at muscle functions, they were quite synergistic. But when we measure the joint vibration alongside it, you will clearly see that ideally they should be flat, but the right side is vibrating a lot, and the left side has some vibration as well. When we do a spectral scan, we will see that the left, compared to the left side, the right side is more hyperactive. Now, what does all of that mean? So if we were to summarize the findings for this case right here, they have a preferential deviation during jaw opening, they have a deflection during jaw closing, they have a deviation to the right side of 12 millimeters, bilaterally equal lateral excursion, meaning that they have normal excursions, normal muscle functions, but chronic disc displacement of the right-sided TMJ and a stuck right disc, suggesting a posterior reducing disc displacement before tooth contact. So all of this you can get from a few graphs and just by looking at the patient. Now, you will think that this takes a long time to do. All of this usually takes between 10 to 15 minutes to do. And gathering a detailed history takes probably another 5 to 10 minutes. So within 15 to 25 minutes, you have a clear understanding of where they're coming from, what's the issue, and how the jaws might be managed before you manage the dental condition. Now, let's move on to the second case. For the second person, you will see that the jaw movement has some deflection, but it's absolutely fine. We don't usually consider anything below 3 millimeters to be an anomaly. It might just be normal. But you can see that there is a tiny deflection during opening, which immediately might suggest that they might have an anteriorly displacing disc. We'll need to figure out where it is. Now, you can see that the left and right-sided movement are grossly ununiform, meaning that the left-sided excursion has 11.6 millimeters to them, while the right side only can do 8.4. You can see that right here as well, where the masseter of the left and right side have a 68% synergy, which is barely at that level. And if we were to have a look at the joint vibration, you will also see that there is low amplitude vibration with an anterior reducing component in the left TMJ section right here, which can also be transmitted to the right as well. So let's put this all together. So the findings are deviation during lateral jaw opening with no deflection. There is a limited right-sided lateral excursion of 3 millimeters. And this is important because the left side has some issues in the joint. So opening TMJ displacement, a hyperactive left masseter muscle, low amplitude vibration and anterior reducing left TMJ, and right TMJ demonstrating chronic adaptive disc displacement right here. So you can get all of that right there on paper with supporting evidence should you decide that, okay, this needs a specialist referral or this needs an MRI to back this up. And it serves as a justification, especially when you ask a patient to do a CT scan and they're concerned about the radiation and they keep asking you for justification. You can't just tell them that I heard a pop, I see your jaw moving, I feel like you're having pain, that's why I need you to do this. This serves as a more fundamental or strong reinforcement technique right here. For the third case, you'll see that they have a normal mouth opening and closing, but there is a bit of deflection right here at maximum opening. Now, this is important because a lot of patients or cases would have this deflection if they feel like one of their joints or both of their joints are restricting and they end up habitually tilting their head to one side while maximum opening. And this is what you can see right here. And this is the movement that she was doing in this process. You will find that the left and right excursions are fairly normal, and there is some synergy, albeit with some weakness, and this can be attributed to their age. But when we see the joint vibration, we will see that they are all over the place. Now, let's just put this together. There is a 3 millimeter deflection in opening, and there is adequate lateral excursion, meaning that the opening is not to compensate for any kind of lateral movements. There is good bilateral muscle synergy, the medium integral joint vibration, and the transferless pattern, which means that the right-sided vibration is not being transferred to the left and vice versa. The transferless pattern would suggest bilateral disc displacement, and the low peak median frequencies are also suggestive of ligament laxity, meaning that their ligaments are slowly loosening up. And sometimes this might be attributed to degenerative symptoms, degenerative disorders. And for this person, they did have a history of osteoporosis, and they were planning on starting a session of bisphosphonates within a week. So the history lines up with the findings. It's just that knowing what questions to ask, because they might not know right off the bat. And this kind of helps us understand, okay, this is something that we need to be careful about. We can't put too much load on their joints. We can't prolong treatment because it might cause soreness or it might cause more damage in the long run if we keep doing this over and over again. For the fourth case, you'll find that the jaw opening and closing are fairly okay-ish. There is some dent right here, but nothing too alarming. The lateral excursions are normal. The muscle functions are fine. But when we do a joint vibration for this, and specifically on the anterior protrusion, we will find that the high integral joint vibration on the anterior protrusion suggests that disc displacement and possible locking out, which means that the person might, from these graphs right here, have a right-sided posterior disc displacement. And you will understand this when you ask the person to protrude and retrude several times, and they will visibly tell you that they're scared that their jaws might lock out. Sometimes you feel like it's okay to reassure them that, no, it's fine, it won't lock out. But most of the times what happens is their gut feeling might be right. Like in this case, there is a good chance for it to lock out because you could actually see the pop happening in the graphs as well as you can hear it in the clinic. So it's usually good to give these cases a good amount of rest in between whatever treatment that you'll be doing. For the last case, you'll find that I'm going to reinforce as to why I felt that they had a parafunctional habit that they were unaware of. So you will see that the jaw opening and closing are fairly normal, very consistent, no deflections, no deviations. The jaw opening speeds are fine. Closing, there is no dip or dent, rather a gradual deceleration during closing. What this means, I'll get to that in a bit. But you'll see that the lateral excursions are fine. you'll see that in the muscles section, the masseters are hyperactive compared to the temporalis, but the joint vibrations are fairly normal. Now, what this means is when they're closing their jaws, the hyperfunctioning masseters get tired out while closing, which is why it decelerates the process of closing the jaws. Now, the contraction decreases, which is why the speed decreases, which is why you'll see a uniform deceleration. And what the point I'm trying to make is the uniform decrease in closing velocity suggests muscle fatigue, while a relatively normal joint vibration with hyperfunctioning masseters suggests a possible parafunctioning habits. And this is something that you can bring to the patient and suggest that, okay, you might have something like this. I think it will be best if you would ask someone to reconfirm, or we can just go ahead and give you a night guard just as a means of precaution. It's always good to prevent something before something bad happens in the process. And other techniques that we use are optic tracing, whereby we ask the participant to sit straight and we ask them to do jaw functions, we ask them to speak, and we use different AI visions to see how their jaws are moving. And it helps us create a non-invasive, non-contact method of evaluating whether they have anything that we need to further investigate. This is an incredible starting tool before we attach any kind of devices onto the patient. It reduces the level of apprehension and increases the trust and confidence. Now, if we want to see whether a physiologic rest position would help the patient, we can do wearable headgears with a strap-on component, which would push their jaws back into centric relation and retruded contact point or contact position, and we can ask them to move their jaws and see if it is of any benefit. And the beauty of this part is it does not require much intervention or repeated reinforcement while we're doing all of this. And all of this kind of comes together. And when we put all of this together while evaluating whether there is a joint component or a jaw component or a muscle component, it helps us plan our dental treatment better, especially for orthodontics, especially for prosthetic rehabilitation, and more importantly for implants, which are more prone to fail if there is an undue occlusal force that might not be because of the occlusion itself, or might be just because of the TMJ complex. And these are the references that I used alongside the cases that I was displaying. And thank you. That's all I have for now.
Thank you so much, Dr. Farouk. It's very interesting. I really like it. You touched on a very, very important aspects that any specialty in dentistry that they need to be aware of these issues, because in many times they just provide the treatment, but they don't know the consequences or the habit that the patients they have. And the good thing that I really like is kind of visualizing everything and easy to understand. That makes the treatment is very, very easy. Make an evidence-based operation that will support the patients if they need to go further for MRI or CBCT or stuff like that. I have one question. Do you use a video to record the movement of the jaws while you taking this kind of measurements?
Yes, we do. We do. So it is very important that we have a video recording going on for the entire process, because we need to see exactly what the patient was doing immediately when we see something abnormal, because sometimes it might be just as simple as the patient yawning, which creates a very odd vibration. And when we put the video side by side with the measurements, and by video, we're also using real-time tracing to make sure that we have a reading of how the jaws are moving in the video so that we can correlate to the readings as well. So it kind of negates operator-related biases as well and human errors, as well as give us a broad perspective of what's going on. So a video recording is quite necessary for this entire thing.
And for the recording, I mean the non-touch devices, it's very interesting and promising because that's another, direction for sensors to work a lot on the movement and the facial expressions and everything. So is it possible? I mean, is it?
It is possible.
Okay.
It is possible, but there are some caveats to this. For starters, being when we're using non-touch devices like video recording, like what you will find with ModJaw, because ModJaw also uses cameras to measure jaw movements and occlusion. Now, you will find that a point of calibration is very difficult to do because it needs to be stationary, because the camera does not know the dimensions or the exact depths of the person's face, which means that, say I'm sitting right here and the person moves like this, the camera does not know your facial dimensions anymore, even though it has already seen it for several hundred frames before that. Now, why this is important is because when we're using wearable systems or when we're using contact systems, it's completely attached to you and it's reading data in a fixed manner. Even though it's relative, it's stationary relative. So it gives us a bit more reliability in readings. That being said, once the non-touch systems are well calibrated for that particular person, it is very, very accurate. So at the moment where we are with digital technologies is we need to find a right balance between the two and try to keep both of them together, because camera recordings are pretty cheap and the devices themselves can serve as an adjunct to all of it together, and we can get more data along the way.
Very good. And one more question from me. Communication of the data. Because we are in digital era and it's very important to communicate data. I think with this all digital ways to evaluate patients, how the communication between dental specialists and non-dental specialists work?
So from my experience with a few of the tools that are commercially available, there are ways of generating reports and sending the reports to different platforms, maybe a laboratory or maybe a specialist. Now, that is the mainstream way of putting it out. But sometimes if you see something which is an anomaly, you might want to clip the readings, you might want to take screenshots of those particular areas, put them together into a form, and you can create your own referral sheet, or you can create your own history or a statement of evidence. There are several ways. Most of the software have inbuilt systems to communicate with the laboratories. There are some subscription costs involved to it, but if you wanted to go the cheaper route, it is entirely possible for you to export the data and create your own forms in the process. Because if you create one form using a template that you feel comfortable with, it's only a matter of putting the data in for each patient and then just sending it on.
Okay, so we have two questions from Dr. Abdul Majid Oksha. Thank you very much for your amazing lecture. Is there any way to deliver the acquired data digitally to the dental lab? Because when you make the reconstruction treatment, we need to have good communication with our labs to get the best results.
So for this case, I think I might want to refer back to my time in Malaysia when I was working with the reconstruction team. So when we were working with MaxFac Prosto teams, we found that a lot of our designs needed to be transferred to the digital labs for 3D printing of prosthetic templates. Now, the communication becomes quite difficult if we're trying to follow a strict pattern. So you have all the data at hand. Some authors or some previous publications suggest that you create movement movies. What that means is you just start recording and you just play the entire movement sequence, and it forms a 10-second or 15-second movie, and it helps people in the labs understand, okay, this is exactly how the jaws were moving, because they have the facial video recordings alongside it as well. So when they see both of them together, they know, okay, this is exactly how it was going. This is the shortest way to go about it. And there are other ways, like we used to send detailed reports over. And sometimes if a technician would want us to elaborate on this, we could ask them, how would you like for us to put this together? And we can send it over. So most of the times what we find is, since we're not working with 3D objects or STL files or maybe OBJ files, it's easier to send this over maybe some communication system. Like there are several tools that help you send data confidentially. And for hospital systems, you have ways of sending it internally without any interception. So it can be done specifically for jaw movement tracing or video recordings, which do not consume a very high sized files, and it can be opened in almost any computer out there.
Okay, his second question, do you have any experience with Titan system? And if yes, how do you evaluate the system?
So if I am looking at Titan right, because
Yeah.
I have not used Titan before, but I'm looking at what exactly they're doing. And from my understanding, it's a bone conduction system, which is a vibration analyzer. So it's a vibration analyzer come muscle activity EMG electrode. So I think the fundamentals would be the same, meaning that it's an electromyography and a vibration analyzing system baked into one. The fundamentals are fairly the same, which means number one, it needs to be the skin underlying the sensors need to be free from any kind of grease, makeup, and heavy facial hair, because that creates impedance and prevents the sensors from sticking. And then if placement is also very important, and sometimes calibration is also important. So sometimes when we place them over the skin and the muscles and we don't get the person to rest before we place it, it some can mess up the calibration. And I have found that to happen quite a few times with our EMG sensors. I cannot say for certain if this will happen with T10 as well, but I'm fairly certain after seeing what I saw with the electrodes, there is a possibility. And you will also find that, at least what we found in the clinics, was when we were peeling the electrodes off, it would create so much impedance that it would create resistance. And sometimes it would be painful for the patient, in which case we found it usually good to ask the patient to peel it off themselves. What that means is, for this entire process, we ask them to help us put it on. We ask them to help us peel it off. And in this process, they know exactly how their contribution is helping towards getting meaningful data. And when you put it all together and when you see it in the screen, they just try to see it on the screen with the patient. That helps them return to rest. And when they're at rest and when you ask them to do certain activities, you will see how they act up. And I think, based on what I saw with the T10 scan, it is a way of evaluating whether your temporalis and masseter muscles react to different movements, which would essentially be chewing, clenching, mastication, then swallowing, and other movements. Although swallowing, not so much, because the SCNs and the digastrics are not there. But what it might be looking at is if the muscles of mastications are hyperactive or not. Now, why getting the patient involved in the process is very important is because when they see why you want to get these readings, it helps standardize the normals more. They're not stressed, they're not tense, they know exactly what kind of data you're looking for. And most of the times for muscle activity and analysis and vibration analysis, it's quite subjective, and it's a combined effort from what I have seen with the 30-something people that we've used it on. And yeah, that's about all I can talk about the Titan.
Yeah, thank you so much. Thank you so much. I think with those two questions, we are going to conclude our webinar today. So, Dr. Farouk, thank you so much for your time and effort to share with us your valuable experience in this topic. Myself really enjoyed the lecture and it's very interesting. And as tradition for digital topics, we would like to present to you a certificate of appreciation. So we hereby express our sincere appreciation to Dr. Taseef Farook in recognition of his contribution as a live webinar speaker for the Digital Topics webinar series on the topic of jaw movement analysis within the digital workflow. That was presented on Thursday, July 20th, 2023. Taseef, thank you. Thank you so much for everything.
Thank you so much for having me on. Have a lovely rest of the day, Dr. Al-Basti.
Yeah, thank you. Thank you so much, everyone. Just be tuned. We have still bunch of webinars on the coming days. So stay there and see you all in the upcoming webinars. Have a nice morning, nice afternoon, and nice evening. Bye-bye, everyone. Bye, Tasif. Assalamu alaikum.
Walaikum assalam.